According to the Centers for Disease Control and Prevention, between 2012 and 2016, 94,000 women were diagnosed with gynecologic cancer. The good news is that once diagnosed, gynecologic cancers are treatable, some even curable. Other GYN cancers can even be prevented altogether. On this week's Health Talk, we're going to discuss the prevention and diagnosis of gynecologic cancer with an expert in the field. So stay tuned for an informative show. Health Talk is up next. Hi, I'm Dr. Eric Mazer. Today our topic is progress in the diagnosis of gynecologic cancer. Our guest is Dr. David Dew. He's a gynecologist specializing in gynecologic oncology. Dr. Dew practices at the Whittingham Cancer Center here at Norwalk Hospital. Dr. Dew, welcome to the show. Welcome to the Norwalk area. I know you're one of our new physicians this year.
Absolutely, thank you.
And we're so glad to have somebody with your expertise here.
Happy to be here.
When I was practicing medical oncology, we were always searching for a great gynecologic surgeon because it's really such an important part of GYN cancer management.
Absolutely.
But I know we want to talk about the prevention and diagnosis of gynecologic cancer in this segment. So I'll just throw that to you. What are some of the things that we know about preventing or early diagnosis of GYN cancer? Maybe you should even review what are the gynecologic cancers we're talking about.
So when we talk about gynecologic malignancies, really we're talking about ovarian cancer, which is the one most people think about. But then there's other cancers such as uterine cancer, cervical cancer, and vaginal and vulvar cancer as well. The most common gynecologic cancer is actually uterine cancer, specifically endometrial cancer, which describes the lining of the uterus. Mm-hmm. And that affects about 65,000 women per year in the United States.
Now, I know the Pap test is used for cervical cancer.
Right.
Can it also pick up uterine cancer?
So occasionally it can. It's really not designed for that. We'll have abnormalities on a Pap that might suggest uterine cancer, but that's really not the purpose of it. Fortunately, uterine cancer has pretty good symptoms that most people will recognize as abnormal. And so that would be either bleeding after menopause or abnormal bleeding before menopause.
You want to emphasize, because that's really important, because uterine cancer bleeds in an abnormal time.
Correct.
So postmenopausal, you shouldn't be bleeding at all, right?
Absolutely, yeah. If anybody has any bleeding after they've gone through menopause, they need to be evaluated right away by a physician.
And for the premenopausal women, they're not free from getting uterine cancer either, right?
That's correct. It's less common in the premenopausal population, but certainly it does happen. I think the youngest patient I've ever seen is 23 years old, diagnosed with uterine cancer. And so any change in your menstrual cycle, increased bleeding, bleeding between periods, or anything that just seems not right needs to be evaluated.
Now, I know that back when in the dark ages, I learned that prolonged estrogen exposure is one of the risk factors for uterine cancer, uterine lining cancer. Are we still seeing that with some of the new birth control pills? Are there women at risk for this, and who are they, and what should they know?
Yeah, so I think it's important to point out, first of all, that birth control pills do not increase the risk of developing uterine cancer, and they actually reduce your risk of developing ovarian cancer.
Because you're sloughing at the end of each cycle.
That's right, that's right. So really when you talk about the exogenous hormones, so if someone's taking extra hormones, particularly after menopause, so if they're taking hormone replacement therapy such as estrogen, that potentially will increase their risk for uterine cancer unless they're also taking progesterone, which is the other female hormone at the same time. Really the most common source of estrogen that causes uterine cancer is in fact obesity. And obesity is the #1 risk factor for endometrial or uterine cancer in the United States.
Now remember, we used to say fair, fat, fertile, and 40. That's sort of the way to remember the risk factors for uterine cancer. Could you explain that? I understand it. I know it has to do with the metabolism of hormones in fat tissue. Could you explain that to our audience? Though I think a lot of people may not realize that.
So fat actually can convert hormones, really male testosterone-like hormones, into estrogen-type hormones, which then drive the lining of the uterus to proliferate or grow. And this abnormal growth is what causes either precancers or cancers of the endometrium. And so prolonged exposure is usually most commonly due to obesity in either the perimenopausal or postmenopausal period for most women. But like you said, other things such as hormones that women are taking, hormone replacement therapy, some other exogenous hormonal things such as tumors can also cause.
I know some of the antineoplastics, the tamoxifen particularly.
So tamoxifen,
estrogen-like.
Yeah, can have an estrogen-like effect on the uterus as well.
Now, endometrial cancer, uterine cancer, because of the bleeding, is it usually picked up early enough to be cured?
Yeah, for most people, especially if they go to the doctor to be evaluated, most people is diagnosed at stage 1, which means it has not spread outside the uterus, and so that's treated with a hysterectomy. And
so
here,
you as a surgeon, as a gynecologic surgeon, you can cure that.
That's correct. And fortunately here at Norwalk Hospital, we have a robotic surgical platform which allows us to do that surgery and other complex surgeries minimally invasively, so the patients can either go home the same day or just spend one night in the hospital.
And I find that absolutely amazing now. I've actually played at those panels, and
it's amazing.
It's really, you can stop criticizing your kids for playing video games because it's three-dimensional. It's truly amazing.
Yeah.
And I'm sure as a surgeon, you can see difficult areas and deal with difficult, anatomically difficult things, which, as a surgeon working from the top, you couldn't possibly do.
Absolutely. And it's really neat because each camera actually has 2 screens on it. So you get a 3-dimensional view. You get wrist motion with the robot that you don't get with laparoscopic instruments. There's a whole slew of things that just make it a...
That's a whole topic for another show. But
we'll talk about it later.
But it's a great, great. But so uterine cancer. Now the other, let's talk about cervical cancer.
Okay, cervical cancer.
That's one, boy, there's some really good news out there. Tell us about cervical.
So cervical cancer, so that is one of the few cancers that can be screened for and potentially prevented. As everybody knows, the pap smear was invented in the 1950s and has dramatically decreased the incidence of cervical cancer because we're catching cancerous and precancerous lesions early. Whereas it was once the most common cancer in the United States, now it's actually relatively uncommon.
But now, cervical cancer was highly controlled, not eliminated, but highly controlled by just swabbing the cervix regularly, looking for cancerous cells. But then we learned that it's associated with this virus.
Right.
So now tell us about, because we can prevent cervical cancer.
That's right.
In people.
So the human papillomavirus, also known as HPV, causes 99% of cervical cancers. It can also cause penile cancers, anal cancers, and oropharyngeal cancers as well.
And really emphasize, this is a big actor. This is a virus that causes cancer.
Right.
And we now have a vaccine for it.
We do, and we've actually had the vaccine since 2006.
Yeah, but it's been hard getting people to take it, hasn't it?
It sure has. In fact, they did a survey in, I think, 2017, and only about half of adolescents in the United States have gotten the full vaccine, and which is, if you told somebody, hey, I can prevent you from ever getting breast cancer or ever getting lung cancer or colon cancer, then you jump all over it. But for some reason, cervical cancer is not.
Some people feel that it's giving people license to have premarital sex or something like that. But I think you just emphasized it. This is a vaccine that prevents cancer.
Absolutely.
It's 99%. And the cervical is the big one, but we're also, as you said, talk to all the others. Boy, I'll tell you, I've got granddaughters who are at the age now who should get it, and I think they've gotten it. Yeah. I would run to get that vaccine.
Oh, absolutely. And ages 11 to 12 is the optimal age. And it's available to both girls and boys.
And that's new. They recently added the boys. Right. Tell us about that.
So it also prevents against other types of HPV that don't cause cancer. So HPV, in addition to causing those cancers, also causes genital warts, which can be a big problem in boys, men or women. And so that's kind of a big driver as well. But also, it also helps with the idea of herd immunity, where if men don't get HPV, then they don't give it to the women, and so then it becomes less of a problem.
So there's, men, to step up to the plate. This is a way you can protect your future partners. And you recommend the same age group, to 11 to 12?
Yeah, it's 11 to 12, although it is approved up to age 45. It's the efficacy and the ability to prevent cervical cancers and precancers is somewhat diminished after the age of 25 or so.
Isn't that because the women have already been exposed to the virus?
For the most part,
they have it?
Yeah, most women, by the time they reach their mid-20s, have been exposed to HPV at some point. And to be clear, most women clear HPV like any other virus. There are some, though, and we don't really know why some women don't, but there are some that don't clear the virus, and those are the ones that go on to develop cervical cancer.
So this is great news, and again, there's a message to take home from this, and that is, if you've got grandchildren, if you've got children, male or female, they should be thinking about the HPV vaccine at 11, 12, 13, before they get sexually active.
Exactly.
Not giving them permission, you're saving them from a cancer death.
Absolutely.
Having cancer.
Absolutely.
Let me move on to ovarian cancer, because that has always been the problematic one for early diagnosis. I don't remember the data, but it was only a small percentage who were diagnosed early, and I guess most patients had stage 3, where that meant the ovarian cancer spreads a little bit differently than most other cancers. It studs the peritoneum in the abdomen. So what's the latest in prevention, diagnosis? We'll talk about treatment another time, but prevention and diagnosis of ovarian cancer.
So ovarian cancer, unlike the other cancers that we've already discussed, unfortunately doesn't have a screening test that's effective, and also doesn't have really definitive symptoms that can help us pick it up at an early stage.
And can I start, because people will say, well, you know, how about transvaginal ultrasound? And I know that some people will even use that. Why is that not considered a definitive screening?
And so that's been studied multiple times in various countries, including the United States. And what it's concluded is in the average risk population, doing routine screening does not reduce the risk of most people dying from ovarian cancer. In other words, they're still just as likely to get it and just as likely to die if they're getting routine screening than if they're not. Whereas on the other hand, they're at an increased risk of needing a surgery or some other procedure.
Right, so you end up picking up things that you, by ultrasound, that you think might be cancer. You have to operate on them to look at them.
And that's the problem. You know, the problem with ovarian cancer, which is actually also a good thing, is that it's relatively rare. And so only about 1 to 2% of women in the United States will get ovarian cancer. But for a screening test to be effective, as you know, it has to be a relatively prevalent disease. So there has to be a lot of people getting it, and there has to be an easy way to pick it up. And really, ovarian cancer doesn't tick either one of those boxes.
But there is a subgroup of people who do have a high frequency of ovarian cancer, who have some genetic abnormalities. Could you talk about that and how your approach might be? And I think most people have heard of the BRCA genes, BRCA1 and 2 genes. Say a few words about that and how that affects your diagnostic approach.
Sure. So BRCA mutations are the most common mutations that are found in people with breast and ovarian cancer. Anyone with a family history of breast cancer or a family history of ovarian cancer really needs to be evaluated by a genetic counselor to determine whether or not they should be tested for BRCA genes or any other genetic mutations that might increase their risk. BRCA mutations can increase your risk of ovarian cancer up to 40% over the lifetime of a patient, which is incredibly high. And so we definitely talk to those women about, we do screen those women because they have a higher chance of developing ovarian cancer. And we also talk to them about having prophylactic surgery to remove their tubes and ovaries before the age of 35 or 40 in order to reduce that risk.
And after they've had their family.
Correct, exactly.
So I think that, so there's a lot of nuance going on now. We've run out of time, believe it or not. And there's so much more we could talk about because the average ovarian cancer does not get picked up, as you said earlier. Their symptoms are vague, but we'll have to talk about that another time. Okay. I want to thank our guest, Dr. David Dew, for joining us on Health Talk today. And please at home, if you would send your questions and comments to us at healthtalk@newvancehealth.org. We'd love to hear from you. Thanks for watching, and get your screening tests. Get the HPV vaccine. Take care.
We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.
145 over 92.
180 over 111.
182 over 100. And I had a heart attack and a cardiac arrest, and then a stroke.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself, I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. Coming back. Ask your doctor, check your blood pressure.
Women faced with gynecologic cancers have more treatment options available today than ever, thanks to the rapid progress in medicine and technology. Research in cancer treatment is progressing at a breakneck speed. A gynecologic oncologist who's passionate about advancing this field through research is my guest on this week's Health Talk. So stay tuned for an interesting and informative show. Health Talk is up next. Hi, I'm Dr. Eric Mazer. Today at Health Talk, we're going to discuss progress in the treatment of gynecologic cancers. My guest is Dr. David Dew. He's a gynecologic oncologist who recently joined the oncology practice at Danbury Hospital and Norwalk Hospital, part of the Nuvance Health System. David, it's so good to have you on the show.
Thank you
and
for
of course, as an oncologist, I love to talk about gynecologic oncology. What's new in the treatments? I know there's so much to talk about.
Sure.
But what would you say are sort of the newest things in the line, and then we can sort of go back and talk about some of the other stuff.
Yeah, and so when we talk about gynecologic cancers, a lot of them will be treated with surgery.
Yeah, maybe we wanted to review again. I'm sorry.
Sure.
The 4 gynecologic cancers, the 5 that we're talking about.
Right. So we're talking about ovarian cancer, uterine cancer, cervical cancer, and then vaginal or vulvar cancer. And so most of those cancers will be treated primarily with surgery, but a lot of them are also going to require some sort of treatment afterward, whether it's radiation or chemotherapy or some other sort of drug therapy.
So maybe we could talk about surgery, especially for ovarian cancer. Maybe, you know far better than I, but that used to be a tremendous operation where you open up literally the entire abdomen and you go behind the liver and you look for implants because as we will talk about, removing as much of that the cancerous tissue as you can really relates to possibly curing the patient later.
Absolutely, yeah.
So has that surgical process changed with some of the new techniques?
Well, it has and it hasn't. And so like you said, the most important thing for ovarian cancer is removing as much of the disease as possible. For patients who have widespread abdominal disease, they have 2 options. The first option is to get chemotherapy prior to surgery to try to shrink some of that disease down. And the second option is to go ahead and do the surgery in an attempt to remove all of the visible disease. When they have widespread disease, really the best way to deal with it is with an open incision, and just because you can really make sure you don't leave anything behind.
How about getting around corners and things like that or behind the liver? Are there any little tools that help you do that any better?
Actually, they're kind of been the same way it's been for a long time.
So you just need a tap. This, I should say, from an oncologist standpoint, this is where we looked for really talented surgeons. Because this is not a routine, easily done procedure. Right. You want somebody who appreciates how important it is to remove as much disease as they can, and also somebody who is capable of looking in all the spots where the disease hides. So, I mean, this is your specialty. So I just wanted to emphasize that you're a special kind of surgeon who can do this. It's not your average person shouldn't be doing this for cure.
That's right, and they've actually studied this, and surgeons who have been trained to treat ovarian cancer have better results, and the patients have better prognosis after their surgery and chemotherapy than those who went to other types of surgery.
It's an unusual disease, and that's that. I mean, again, we don't usually treat metastases surgically.
Right.
There's some instances.
It's kind of an unusual
except
cancer.
for ovarian. And ovarian, for reasons that are never. Do you understand why? But for me, it's a different kind of cancer, and removing as much of the disease as possible. We know we leave some behind anyway, but it significantly affects the outcome.
Yeah, and a lot of that I think has to do with the blood supply to the tumors themselves. Some of the tumors outgrow their blood supply because they get too big, and when that happens, the chemotherapy can't get to those tumor cells. And so when that happens, the chemotherapy is not going to work as well as if you had all those big bulky cancers out of the way. And so when you take it all out other than microscopic disease, you have a much better chance of the chemotherapy being effective.
So it's just simply the chemotherapy getting to those cells and curing it. So keep going. What other new things are you seeing in terms of the treatment of the different gynecologic cancers?
Staying with ovarian cancer, I would say that the most important new treatment of the past several years is the development of PARP inhibitors, which is a new class of drug that's an oral drug that ovarian cancer patients can take either during or after chemotherapy. And in some patients, it has a dramatic improvement in their overall response to chemotherapy and their overall survival.
And they take that indefinitely?
So the studies have looked at taking it for 2 years, and particularly in patients with BRCA mutations or other mutations that are going to be examined in their tumor. And if they have these specific mutations, then they take this oral drug for 2 years after they're finished with their chemotherapy, and it decreases the risk of the cancer coming back from about 80% to about 50% in those patients, which is a huge improvement.
And this is actually the story of medical oncology in the last 10 to 15 years. Again, I don't think I've long felt that there is a revolution going on in cancer therapy that is underappreciated and underreported by the media.
Yeah.
The drugs that are being developed are amazing. They are targeted. They exploit novel mechanisms of action. Even some of the checkpoint inhibitors, some of these immune things that induce an immune reaction. So I think we really personally believe that next 10, 20 years, we're going to be able to cure most cancers or control them at least for the long term.
I hope so.
Do you have any other feelings? Because you're coming into the field, I've just left the field, but I just see this, what's going on right now is absolutely profoundly different than what went on in my youth.
I think that one thing that's pretty remarkable is, whereas 20 years ago, any improvement in treatment might increase the survival by a few months, 3 months, 6 months at a time. Some of these new treatments are, for some patients, prolonging that for years, and so the difference in the effect of these treatments is so dramatic in the right patients with the right mutations that it's really remarkable.
And you mentioned mutations. Maybe you could say a few words about how understanding the DNA profile of a tumor has really begun to change the way we even think, the way we think about treatment.
Yeah, and so particularly in ovarian cancer, when we have a patient with ovarian cancer, we send their tumor off to look at a whole slew of potential mutations in specific genes within that tumor, because as cancer grows, it develops new mutations all the time. And so that's kind of what defines cancer, is its mutated genome. But as if we're able to test for these mutations and target them specifically with various drugs, then that will vary drastically on the response of those cancers to the new drugs that we're talking about.
And this is true across the cancer spectrum, is that we now realize that there are dozens of driver mutations or mutations which are specifically making this cell cancerous. And we should say with a mutation is a change in the DNA structure, oftentimes small, but it changes the behavior of a gene.
I mean, think of a gene or a cell being in balance with certain genes that cause it to grow and certain genes that cause it not to grow. When the balance is tipped to the growth side, it causes a much more prolific growth of that cell and eventually can lead to a cancer. And so the genes that are causing those growth drivers, as you said, are going to be the ones that we're going to target with these drugs.
Yeah, and there are more than dozens and dozens of new drugs now that target these different drivers. And this is a new kind of personalized medicine, isn't it?
It is. That's exactly right.
Because when you're talking about an ovarian cancer and doing the DNA profile, you're talking about for that specific patient, right?
Exactly. Every patient has their own specific profile and their own mutations in that cancer. And so we test every single patient so that we know which drugs are going to work for them.
And sometimes, again, I don't know where the overlap is, but I mean, a drug that may work if there's a mutation in ovarian cancer and there's a mutation in a lung cancer that are the same drivers, you can use the same drug then to treat them.
Potentially so, yeah.
Again, I don't know how that works for ovarian.
Yeah.
So what are some of you mentioned the PARP inhibitors. Are there other new drugs that are more frequently being introduced to ovarian cancer?
Well, you mentioned people who are having checkpoint inhibitors, and that's being looked at in ovarian cancer. In particular, checkpoint inhibitors are being looked at in conjunction with PARP inhibitors. And so what checkpoint inhibitors do is they take advantage of the immune system, and they use the immune system to attack the ovarian cancer cells. We're doing a lot of testing right now in clinical trials to determine if combinations of the immune system or checkpoint inhibitor drugs with PARP inhibitors and traditional chemotherapy can cause an even better response than what we're
I think I saw an article just recently about
Yeah.
that. But the checkpoint inhibitors are another sort of mind-boggling field to me.
Yeah.
And maybe to explain to folks at home that cancers are a little bit different than normal tissue often, and they express proteins on their surface that are abnormal and shouldn't be there. And normally the immune system will attack those proteins and kill the abnormal cells. That's how we protect ourselves from bacteria. But what happens with a lot of cancers is they produce substances that hide those doing, and they turn off the immune system.
That's right.
So you talked about PDL, the checkpoint inhibitors, PD-L1 inhibitors. So tell us a little bit more about it. I just find it amazing that we can turn on the immune system to kill cancer. This was sort of the dream 50 years ago, but it's working now.
I mean, if you think about it, cancer cells are your cells from your body, and your body is designed not to kill cells of its own, right? And so the cancer cells take advantage of that with certain proteins that are expressed on their cell surface that tell the immune cell, don't kill me, don't attack me, and they kind of interact with that way. And when we have a specific molecule that blocks that interaction, it can cause the immune cell then to recognize that cell as foreign, as an enemy basically, and it then attacks and kills the cancer cells that all look similarly.
So and this is probably in the future for ovarian cancer. I mean, it's being tested now.
I mean, we've been testing it for several years now. We've tested a lot of these drugs, like I said previously, individually just for ovarian cancer, and we've had kind of mixed responses, but we're hopeful that with combination therapy with some of the other drugs that we've been talking about, that it will be a little bit more effective.
And again, these are incredibly interesting combinations because in the old days we would combine one drug that poisoned DNA with another drug that poisoned DNA and try to get synergy. But here we're really dealing with tiny metabolic processes that characterize these cells.
And it actually works, which is the crazy part.
Which is amazing.
I will say we are using checkpoint inhibitors in cervical cancer and endometrial or uterine cancer, particularly for metastatic or recurrent disease, and they tend to have a pretty good response rate in those cancers right now.
And are you seeing, I know with some of these checkpoint inhibitors, those patients who respond, as you said, have these very long responses. You're seeing the same kind of things with cervical?
And so that's the thing about this, the checkpoint inhibitors is they have these really long, drawn-out responses, which is something you don't see with traditional chemotherapy.
Which may be cures, but again, whatever.
Right.
I mean, if the cancer doesn't grow and it's still there, you would say, well, that's not a complete response. As long as it doesn't grow, that's fine.
That's good. Yeah, we'll take that.
So there's a bright future ahead.
Absolutely, yeah, and it's only getting more and more interesting every day. And we have so many smart people, both here at the hospital as well as around the country working on these things. So stay tuned.
These things are widely available. They should point that out. You don't have to go to New York City to get these drugs.
That's right. We got them right here.
We got them right here.
That's right.
And unfortunately, we've had to run out of time. It's really been fun, David. Speaking with you, getting to meet you. I want to thank my guest, Dr. David Dew, for joining me on Health Talk today. It's been great having him here. If you have comments or questions for us, please email them to us at healthtalk@newhampshirehealth.org. Thank you so much for watching, and stay well.
(145 over 92).
180 over 111.
182 over 100. And I had a heart attack and a cardiac arrest, and then a stroke.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself, I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. Coming back. Ask your doctor, check your blood pressure.